in treating patients because of increasing drug resistance. So we have no other than a better person, Professor Singla, who has almost more than 150 publications in national and international journals and invited speakers all over the globe. So welcome, Dr. Singla. We're very eager to hear your talk. Please.
A very good morning to all of you. It's really a privilege to be here in this institute. My nephew was admitted here a few years back for 40 days with acute pancreatitis, and I used to spend a lot of time with him. And we also always used to wait for Dr. Sareen's sir's round, which were really very encouraging for him as well as for me. And I learned a lot of things from sir. First thing is that consultant comes to the room, talks to the patient, hears him, and then responds. So this was a message for me during that period, and I'm grateful to you for all the help you gave to him and to me also. Thank you, sir. You see, having said that, in the last few years, the new diagnostics are there, new drugs have been discovered, and accordingly we have the new regimes which are there to be followed. And as a result of this, there is a sea change in the management of drug resistance TB, especially. And it is very difficult for any chest physician, general practitioner to really follow up with the changes. And as you will see, the entire treatment regime has totally changed after the introduction with these oral regimes. So I'd like to take you through this in a very brief time of next around 30 minutes, and then we'll discuss. You see, we all know the burden of tuberculosis. As per the Global TB Report 2025, in 24, India was contributing around 25% of the global incidence of TB cases, around 28% of the global deaths are in India, and 1/3 of the global MDR TB cases we are contributing. So we can understand the burden. You see, there was a time when it was believed that in the country, we just cannot treat MDR TB in the field conditions under the national program. So in our institute, we started enrolling the patients who are MDR TB. We worked on them for more than 5 years and then shared our experience. And we shared to the government that yes, we can treat MDR under the national program with some constraints. And the first patient was initiated on MDR TB regime in August 2007. And at that time, the regime was of 24 months with 6 months of injection, which could be extendable. Now the next challenge was, after introducing this, how to manage the patients who are failing to this regime or are pre-XDR or XDR. So for this, you see, we started enrolling patients who are having pre-XDR or XDR. We gave them regime of linezolid with other drugs. We were the first one in the country to start using linezolid as anti-TB drug, along with one team from Mumbai. And we at that time, we did not know the dosage of linezolid as anti-TB. We started with 1200 milligram. And then as the evidence came, we came down to 600 milligram. And this was the initial study which has compared 1200 versus 600 in the outcome and the ADRs. So we found that this regime, where we gave linezolid along with 5 to 6 drugs, it gave favorable outcome in about 72% of patients. And based on this, our government started so-called category 5 treatment for pre-XDR and XDR. Again, more than 24 months, requiring injection 6 months, extendable to 9 months. Before I go for the treatment, I'll just take you through the very important brief laboratory aspects. You see, we want to know the resistance against the key drugs, and these 3 key drugs are INH, rifampicin, and fluoroquinolones upfront. And of course, now we also want to know the resistance to the newer drugs like bedaquiline, linezolid, predominate. We call it H resistance TB when a person is resistant to H, but documented sensitive to rifampicin. It has a different treatment, as we'll see. Then multi-drug resistance, MDR TB, is a laboratory term. We should not label any failure of TB just as MDR. It's a laboratory term, and patient should have documented resistance to at least INH and rifampicin. Pre-XDR TB is H plus R and a fluoroquinolone, which has poor prognosis and difficult to treat. Extensively drug resistance TB is basically pre-XDR along with one of the drugs from group A, that is bedaquiline or linezolid. But let me tell you, the management of both is almost same as difficult. Then we have a very common test which has changed the entire scenario of diagnosis, that is called this expert MTB RIF, popularly called Gene Expert or CBNAT. It tells us about the whether MTB is there or not, and whether in the same test, whether rifampicin resistance is there or not. So within 1 day you have this report, and it can detect even when the sputum AB smear is negative. Very easy sample processing, fully automated system, and results technically available within 2 hours. Dr. Camilla from Hinduja, she says it can be done even by a chest physician. It's so simple. So by monkey, sorry, she said. It can be done by monkey and as well as by any physician. So she equated us with a monkey. It's so simple test. Then the advantages over Gene Expert of this Expert MTB Ultra is there in the market. Basically, it can detect even fewer bacilli. It has slightly higher sensitivity at the cost of slightly lower specificity. But you will find in all the institutes, maybe in this institute also, we are using the Expert Ultra, but our government has still not approved it. But it is a, let me tell you, it is a WHO approved test, so we can rely on the results. Then again, another test which has changed the management entirely is Expert MTB XDR. And here, based on the mutation, it tells us about the INH and fluoroquinolones. These 2 drugs we cannot know by Gene Expert or Gene Expert Ultra, and also tells us about the second-line injectables and ethionamide. So first we perform Gene Expert to know rifampicin resistance, and this is followed by Expert XDR, which will tell us about the INH and fluoroquinolones. So within 2 days, we know whether I'm dealing with a case of MDR or pre-XDR. So it's a sea change in the treatment. I remember in our study which we did, it used to take 6 months, 9 months, 12 months to know in a case who is failing to treatment various issues. The test is not sent, it does not reach the lab, does not collect the report and all that. It used to take up to 1 year to prove that he is a case of pre-XDR or XDR, and here within 2-3 days we come to know. Then we have line probe assay. It tells us we have first line and the second line. First line tells us about the INH and rifampicin, and second line informs us about the fluoroquinolones and injectables. The issue is that it requires special infrastructure and trained technicians. It's not a test which can be taken to the field and can be done by anyone. And also, briefly, you see it has some mutation pattern, like first an LPA for INH. If there is a INH, the INH-G resistance mutation, then it says that person is resistant to high dose INH, but ethionamide can be given. On the other hand, if person has only INH-A mutation, then here the high dose INH can be given, but there is a cross resistance with ethionamide which cannot be given. Similarly, for second line LPA, I am not going to details. Regarding fluoroquinolone, it tells us based on the mutation pattern whether we can give high dose moxifloxacin or not, which helps in treatment building. Then of course you must have heard about the genome sequencing, which includes WGS whole genome sequencing, targeted NGS, and they have a great potential for rapidly diagnosing. You see, otherwise to know the resistance to second line drugs, it again takes 1.5 to 2 to 3 months, but here within 7-10 days we can know that. And this is it also tells us about the newer drugs, bedaquiline, delamanate, pretomanate, linezolid, which is very vital. And this is a typical example of a report. You can see the practically the DST pattern for all the drugs can be seen. Then before proceeding, I must tell you that these are, whatever I have discussed, they are the genotypic tests. They are DNA based and do not indicate active disease. Please remember that. They are useful basically for initial diagnosis, but for follow whether patient is failing or not, or responding or not, they are not there, not to be used. Then we have phenotypic tests, the liquid culture called midget culture. It confirms the diagnosis of TB whenever in doubt. It indicates that the disease is still active if the culture is positive. And by doing culture, we can do the DST to almost all the drugs today, at least in some of the laboratories, including our lab. And it is to be used for follow-up, whether patient has converted or not, whether the bacteria are dead or not, we should use it. Then this is the concept in India being followed and recommended by our government, that among all TB patients which we diagnose today, should have universal access to rapid DST for at least rifampicin. So we should, before we start the treatment, we should know whether my patient is rifampicin resistant or not. And second is, among all the patients, we document rifampicin resistance. We should have an access to DST against fluoroquinolones. So upfront, before we start the treatment, we should know whether my person is MDR or pre-XDR. Now with this background, let us see how should we proceed in a clinically suspected case of tuberculosis as of 2026. So whenever patient comes with symptoms, we perform the sputum for AFB smear, CBNet, which I discussed, and the X-ray of the chest. If we find despite all this MTB is not detected, we look at the other tests like X-ray and whatever relevant tests are there. In few of the patient, we may have to start the anti-TB medication based on clinical, radiological and other features. But we should make all attempts to have microbiological diagnosis so that we know upfront whether I'm dealing with drug-sensitive TB or drug-resistant TB. In case we are fortunate and we are able to document that MTB is present, this is the national algorithm. This is integrated diagnostic and treatment algorithm for drug-susceptible and drug-resistant TB. It looks quite complicated. I'll try to make it simple. So whenever we have suspected case, we have done the CBNet. Either person will be rifampicin resistant detected or rifampicin resistance not detected. Let us start the right side first. So whenever you have rifampicin resistance not detected, we start the drug sensitive TB so that we don't delay, and simultaneously we send the first line LPA. Why? To know the INH resistance. So this is a drug sensitive case, but we have to look for INH resistance. The report comes, it says H resistance not detected. So in that case, we will continue with the drug sensitive TB treatment. Now let us see in 26 what is the treatment for DSTB. So it has, nothing has changed, it remains same. 2 months of 4 drugs, rifampicin, INH, ethambutol and pyrazinamide, which we have been giving for so many years, followed by 4 months of rifampicin, INH and ethambutol. In extrapulmonary TB like CNS, skeletal, disseminated, we need to extend. Thus I'll show you. And we have to use the fixed dose combinations. That is, one tablet is having all the 4 drugs, INH 75 milligram, rifampicin 750 milligram, 150 milligram, ethambutol 275 milligram, and pyrazinamide 400 milligram. And in adults, we have 5 weight bands, depending on the weight. Like you can see here, the weight bands. And according to the weight bands, you see, in this 25 to 34, 2 drugs are to be given, 50 to 64, 4 drugs, more than 75, 6 drugs. So there is a significant change in the dosage of as per the weight band. And if you just see in a 40 kg adult patient, we will have to give this dosage. And in a 67 kg person, almost the dose will be 1.5 times. But unfortunately, when we see the prescriptions in the market of most of the doctors, including allopathic doctors, we find the standard prescription, I'm not naming the market name of the preparation, which is very, very popular. It has INH 300, rifampicin 450, ethambutol 800, pyrazinamide 1500. So you can imagine, depending on the weight, how much underdosing or sometimes overdosing we might be doing with the patients. And recently, the ATS, CDC, ERS, you see these 3-4 organizations very rarely come together. And they issued clinical practice guidelines of 2025. And they suggested 2 regimes, that is 4 months of rifampicin moxifloxacin containing regime. And they conditionally recommended for patients more than 12 years, weighing more than 40 kg, among patients who are primarily drug sensitive TB. And then second regime which has been suggested is based on the SHINE regime, that is 2 months of 4 drugs or 3 drugs with or without ethambutol, followed by 2 drugs of INH rifampicin for children between 3 months to 16 years with non-severe DSTB. You see, both of these regimes have some caveats. There are some logistic challenges. There are some technical challenges. So these were discussed in detail in our National Technical Expert Group. I'm a part of that. Because before we say that no, this is not acceptable to India, we have to discuss them in detail. And finally, as of today, our national program has not accepted these recommendations for field implementations, and please do not use them till our government approves them. Then coming back to rifampicin resistance not detected and the first line LPA done, then there will be a scenario where you have only H resistance. So rifampicin you have already excluded. So these are person with only INH resistance. So here we have to stop the drug sensitive TB treatment, which we were giving earlier, and start the H monopoly drug resistance regime. What is this is? Here what is recommended is 6 months of 4 drugs, that is levofloxacin, rifampicin, ethambutol, pyrazinamide. So INH has been replaced by levofloxacin. Standard duration is 6 months, but it can be extended to 9 months in patient with extensive disease, with uncontrolled comorbidities, extrapulmonary TB, when the smear at the end of 4 months is still positive or any replacement has been done. And some of the situations like CNS, skeletal, biliary TB, the treatment may be given for up to 1 year. Regarding the extrapulmonary TB, for drug-sensitive TB, you see for most of the extrapulmonary TB, whether it is pleural, lymph node, pericardial TB, even abdominal TB, it is standard recommendation is for 6 months, and based on the specialist recommendation in some special situations, it can be extended to 9 months or even more. But as a standard practice, it is 6 months, and the treating physician must refer the case at the end to the specialist to know the end of treatment is justified or not justified. For CNS TB, bone TB, we have to extend the treatment to up to 12 months, and for eye TB around 9 months. You see, these are as per the EPTB guidelines. The government had constituted a large committee where each system specialists were there, around 8 to 10. They reviewed the evidence and then they came out with these treatment recommendations. Main concern was the treatment duration. As we have seen, sometimes they go on giving the treatment which in general is not required as per the evidence. Let us see a case study for H. monopoly treatment regime. So this was a 39-year-old male with fever and cough for 6 months. Patient had taken treatment for 2 months based on the sputum positivity, but did not improve. And at the end of 2 months, sputum smear was 3+ when he came to us. You can see the X-ray. It is not pulmonary TB, but not extensive. And CBNAT showed no rifampicin resistance, but LP showed INH resistance and RIF sensitive. Second line LP showed sensitive to fluoroquinolones and injectables. Culture was still awaited. So this is a scenario where drug-sensitive TB, treated for 2 months, patient does not have extensive TB, and at the end of intensive phase of 2 months, patient is INH resistant and rifampicin sensitive. So this person is fulfilling all the criteria that this patient should be on H. monopoly DRTB regime. Since it is non-extensive TB, 6 months is enough. If this was extensive TB, we will give the treatment for any of the PGs, please. How many months? 9 months. Extensive TB, as we said, the indication of extending to 9 months is extensive TB also, one of them. So now with this, we come down to the management of MDR or XDR TB. We have 3 new drugs, and we should know at least the age criteria, which is very, very important before we choose this drug. Bedaquiline in India has been approved for 5 years and above, weighing at least 15 kg. Unfortunately, this is so. Globally, WHO recommends it can be given at any age, but there are some issues that the lack of evidence by the firms which are making it, they are not able to produce it to the DCGI. So in our country, approved only for 5 years and above. Delaminate approved for any age, but weighing 10 kg or more. And this new drug, Pretomanid, it has been approved only for 14 years and above, and approved for use within the BPL regimen, which I will come to. So you cannot add this drug in any other regime otherwise. So let us see what are the current Government of India recommendations for management of drug resistance TB in 2026. They are entirely different than what it used to be 2 years back. So again, this is the diagnostic algorithm. So we have this drug sensitive TB treatment, H monopoly treatment, and then we have the 3 kind of drug resistance TB treatment, the BPLM, then shorter regime, and the longer regime. I'll come to that one by one. So whenever we have coming back to this rifampicin resistance is detected, we do the various tests, first line LP, second line LP, expert XDR, liquid culture, and then depending on, I'll come to it later, the age, fluoroquinolone resistance is there or not, extent of pulmonary TB, extent of EPTB, mutation patterns, etc. Then we have 2 options. Person is 14 years and above. Second is person is less than 14 years. In the group where person is 14 years and above, first choice we should consider in any case of drug resistance TB is BPLM, whether I can give it or not. In case we cannot, second choice should be shorter oral 9 months regime, and third choice should be the longer oral regime. In the group where person is less than 14 years of age, first choice, because we cannot give BPLM in less than 14 years of age, so first choice is shorter oral regime, and the last choice is longer oral regime. So longer oral regime is like a grandfather embarrasses all the children who other people are not accepting. So coming to the BPAL-AM regime, you see what was the evidence. Initially you might have heard NICS-TB trial was done basically for MDR-TB failures and XDR-TB, or they were not tolerating the drugs. 3 drugs, again first time in the history of the world that for MDR, XDR-TB, 3 drugs, bedaquiline, predominant linezolid for 6 months, extendable to 9 months. And it gave very good results in the form that it had 90% success rate, but here the issue was there were adverse drug reaction to the tune of neuropathy 81% and myelosuppression 48%. And also they linked it to the linezolid dose of 1200 milligram per day, which was used in this trial. So the next challenge was what should be the dose and duration of linezolid. So then this trial was done. 4 arms were there in different doses and duration. And the arm with BPAL with 6 milligram of linezolid throughout the duration of 6 months, it had the most acceptable results with 91% efficacy, 24% peripheral neuropathy and 2% myelosuppression. And then we had final this TB practical trial. It had more than 550 patients with 4 arm, 1 arm only BPAL, that is 3 drugs, bedaquiline, predominant linezolid. Then second arm along with moxifloxacin, third arm along with clofazimine, and fourth arm was the standard treatment regime of that particular country where it was carried out, And then when we compared the results of this, the BPAL with moxifloxacin compared to only BPAL, that is without moxifloxacin, the BPAL-AM had a culture conversion at 8 weeks, 77% compared to 45% in the BPAL without moxi. Similarly, in the modified intention to treat analysis at 72 weeks, the favorable outcomes were 88% in BPAL-AM compared to 76% in BPAL without moxifloxacin. And one of the very important thing in any shorter regime is the recurrence. So recurrence at 72 weeks post randomization was none in BPAL-AM compared to 4% in BPAL. So India has taken a call to give BPAL plus moxifloxacin, and we must know when to give, when not to give. So inclusion criteria, that is when to give it, when to consider it is when we have MDR or RIF resistance with or without fluoroquinolone resistance, but age should be more than 14 years. Person should not have been exposed for more than 1 month to the key drugs like bedaquiline, predominant linezolid. If person has taken it, it should be sensitive, which in field condition we do not know. TNGS we will be able to know. Then female should be non-lactating or lactating female but not breastfeeding. Then female should be non-pregnant or pregnant who was willing for MTP. Now when not to give it. So person who have documented resistance to any of these, bedaquiline, linezolid and or predominant. People who have, please remember, severe forms of extrapulmonary TB like CNS TB, spinal TB, bone TB, miliary TB, disseminated TB, we say TB in more than one organ. You see, unfortunately, as per this definition, even people with minimal cervical gland and also documented to have small abdominal glands more than 1 centimeter in size, they are denied this, and sort of we are working on this, how to include this group. Then person with significant liver dysfunctions, where it has been defined in our national guideline is the enzymes AST or ALT more than 3 times the upper limit of normal, and or bilirubin more than 2 times the upper limit of normal. Then person with significant cardiac conduction abnormalities or the QTCF, that is Friedreich's criteria, more than 450 millisecond in males, or in females more than 470 milliseconds with normal electrolytes. So please must remember, at least if you can't remember entire thing, that it should be given only in people who are 14 years or more, and they should not have severe extrapulmonary TB like CNS TB, spinal skeletal TB, miliary TB or disseminated TB. The other relative contraindications include the drugs having interaction with the bedaquiline, severe anemia like less than 8 gram, platelet count less than 75,000 because of the linezolid, then absolute neutrophil count less than 750, again linked to the linezolid toxicity. Then people with severe renal failure with creatinine more than 3 times the upper limit of normal, and severe neuropathy, of course, is also, rather it should be an absolute contraindication, which we feel. So what about the dosage and administration? So it should be administered with food and water. Please remember it. Sometimes people forget to tell it, as it increases the absorption. It is to be given for 26 weeks, which is equal to 6 months, but may require extension to 39 weeks in some situations. I'll come to it. So the standard dosages are bedaquiline in the first 2 weeks, 400 milligram per day, and week 3 to week 26, 200 milligram 3 times a week. Pretomanate 200 milligram daily, linezolid 600 milligram daily, and moxifloxacin 400 milligram per day. Same dose for all the weight bands. Here there is no weight band as of now, as per the evidence available, and no dose modification of any of the drug is permitted except linezolid, which can be reduced to 300 milligram in case of any intolerance. I'll come to it. So when can we extend the treatment to 39 weeks? So either it is 26 weeks or 39. It is not monthly extensions. So in situation where we have to reduce the dose to 300 milligram because of any adverse drug reaction, but this is permitted only when patient has completed 9 weeks of treatment. If we need to do it before 9 weeks, we have to declare the treatment as treatment failed. Then moxifloxacin had to be stopped permanently due to any adverse drug reaction or any other reason. Then again it should go for 9 months. Permanent stoppage of any one of the drug other than moxifloxacin is not permitted, and we have to declare the treatment as treatment failed. In case of missed dosages of any of the core medicine, that is bedaquiline, predominant or linezolid, we have to declare the treatment as failed in case there is consecutive disruption for more than 2 weeks or cumulative disruption for 4, that is 10 days now, then again 14 days after 2 weeks, like that. So if the total period is more than 4 weeks, declare the treatment as failed and go for the next choice. Looking at the adverse drug reaction, the commonest adverse drug reaction which have been mentioned and encountered also are peripheral neuropathy, myelosuppression, anemia, thrombocytopenia, QTc prolongation, and optic neuritis. In our experience, because as of today the Government of India has not permitted to share the national experience, is we have 240 patient plus enrolled so far. Peripheral neuropathy 17 patients. 7 patients we had to stop the treatment and go for the second choice. In 10 patients they required dose reduction to 300 milligram but we could continue treatment to 9 months, and patient tolerated it well and were cured. Then myelosuppression, that is anemia, we saw in 4 patients, but most of them could be managed conservatively. Usually we give blood transfusion along with the other conservative treatment, and they could do. QTc prolongation we had in 1 patient, where patient had the increased QTc, but we could manage conservatively. However, patient was lost to follow-up, and optic neuritis in our institute we have not encountered so far. Let us see a case. I like to, the PG should contribute to this. So 29-year-old married female, 12 weeks pregnant with fever off and on for last 8 months. Patient had taken the first line drugs irregularly for 5 months, then lost to follow-up, and this is the X-ray which is showing bilateral extensive disease. The lab investigation showed the CB-NET rifampicin resistance, first line LPA INH high dose resistance plus rifampicin resistance, then second line LPA showed levofloxacin, moxifloxacin resistance, and injectable sensitive. Culture is awaited. So this was the scenario that patient reported to us. So if you summarize the scenario, 29-year-old female, married, 12 weeks pregnant, MDR with high dose INH resistance, quinolone resistance including high dose moxifloxacin, extensive pulmonary TB, no severe extrapulmonary TB. So what should be the ideal treatment in this scenario? Anyone please? Anyone? You can make mistake also, no issues. You see, patient is fulfilling all the criteria for BPLM except being pregnant. So in this case, can we give BPLM? No, because of 12 weeks pregnancy. But the second choice which we had mentioned in the inclusion criteria was, in case patient is ready for MTP, then patient is eligible. So patient was counseled, the MTP was done, and the BPLM regime was started. Now suppose patient is counseled and patient refuses that no, I will not like to go for MTP, which happens many a times, especially when the pregnancy is precious. In this scenario, with this features which we had discussed earlier, can we give BPLM? No, because patient is 12 weeks pregnancy and MTP is denied. Can we give shorter oral regime, which is the next choice in MDR TB cases? No, I'll come to it because patient has FQ resistance and patient has extensive PTB. I'll come to it later. Can we give longer oral regime? Yes, this is the last regime which is with us. It can be given, but will need some modification. So you can see with the BPLM in the market, this is the drug sensitive TB treatment in a 55 kg person, 4 tablets, having all the 4 medicines. And this is the longer oral regime, you can't even count the medicine, and this we have been giving so far. And then this is the BPLM regime, just 5 drugs, almost same as drug sensitive TB, which we could not imagine 2 years back. And as per these guidelines, the first patient who was put on BPLM was in our institute on 27th December 2024, and this patient after 6 months of treatment is hale and hearty and is under our follow-up. And if you look at the BPLM regime in the country, many of us are not even aware that almost 22,000 patients they have been enrolled in BPLM. Some people are not even aware that this regime exists. And all states, all the union territories, they have initiated patient of BPLM. No district in the country should say, I do not have access to the BPLM regime. Coming to the next regime, that after BPLM, in case it cannot be given, is the shorter oral bedaquiline containing MDR-TB regime. Again, when to be given and when should not be given, very, very important. In case you give this regime in a person where it should not be given, you are harming the person and there will be augmentation of the resistance. So inclusion criteria have that RIF ratios on MDR-TB without fluoroquinolone resistance, and it can be given to children 5 years or more because it has bedaquiline, and bedaquiline cannot be given in India to children less than 5 years of age. Exclusion criteria include extensive PTB, although BPLM can be given, here we cannot give. Severe EPTB, same like BPLM, that is miliary, CNS, meningeal TB, disseminated TB, it cannot be given. If patient has used more than 1 month of the key drugs in this, again it cannot be used. If person has both the mutations, INHA and CATG, then it has 2 kinds of treatment, I will come to it. The linezolid containing regime can still be given. In pregnancy, the linezolid containing regime can be given, but a thionamide regime cannot be given unless pregnancy is more than 32 weeks. So we must remember at least age 5 years or more, no fluoroquinolone resistance, no extensive pulmonary TB, and no severe extrapulmonary TB. And what is the regime? We have 2 options. The first option, now about 1 year back we have implemented this, is linezolid containing regime. So there are 7 drugs, 4 months of intensive phase, which is extendable to 6 months. It has 7 medicines, bedaquiline for 6 to 9 months, linezolid only for 2 months. Then this rest of the 5 drugs, levofloxacin, pyrazinamide, ethambutol, clofazimine, and high-dose INH. And in the continuation phase of 5 months, we have 4 drugs, levofloxacin, pyrazinamide, ethambutol, and clofazimine. And please also remember, it's a package of treatment. As of now, unless the more evidence comes, it is a package of treatment. All the 7 drugs are to be given, except, so we are not permitted to replace any of the drug, except that in the continuation phase, either pyrazinamide or ethambutol can be stopped, but not both. Then the second regime is where we are replacing linezolid by thionamide. This used to be there for several years, before 1 year. So again, everything remaining same. Instead of linezolid for 2 months, we have thionamide for 4 to 6 months, and it is to be given when linezolid cannot be given due to, most of the time, due to any adverse drug reactions. So if you see, this is the one patient, this is the second patient. In which of these you can give shorter regime, or in both of them you can give shorter regime, shorter 9-month regime? Anyone please? Can we give it here if person has this X-ray? Yes, because it is non-severe. Here you find is a severe extensive pulmonary TB. So extensive pulmonary TB is a contraindication for shorter oral 9-month regime. So here we cannot give. Let us see a case. It's a 13-year-old female with fever and cough for 9 months. Patient had received first-line drugs 2 times. Initial 4 months irregularly, patient defaulted, and then followed by 9 months regular treatment, but failed to the treatment. And this is the X-ray. So you can see it's a pulmonary TB which is not extensive. Sputum CB-net, rifampicin resistance shown. First line LPA, H high level resistance. Then second line FQ resistance, FQ sensitive, and SLI sensitive. So here is a scenario. Person is rifampicin resistance, 13 years of age, no fluoroquinolone resistance, non-extensive PTB. So of course, in any drug resistance, the first choice should be BPLM. Can we give it? Anyone? No. Why? Please come. Yes, why not? Age is less than 14 years of age. That is the reason we cannot give BPLM. Second choice we should consider is the short oral 9-month regime. Can we give it? Yes, because it is fulfilling all the requirements. There is no contraindication. Person has resistance with no FQ resistance, and the pulmonary TB is not extensive. Third choice is the longer oral regime, which is not required in this case. So this should be the first choice always, second choice, third choice. Here we can stop at second choice. Now coming to the next regime, that is, so in this case the shorter regime was given. Now coming to the longer oral MDR XDR-TB regime. So what was the evidence for this? You see, this was a study done and published in Lancet 2018. It changed the entire concept of treating MDR-TB in the world. It was study with the highest level of evidence, individual patient data analysis, more than 12,000, 25 countries, 50 studies, and fortunately we had 3 studies from India, 1 from PGI Chandigarh, 1 from my institute, and 1 from the Mumbai group. And what this study showed, here the role of individual drugs in the MDR-TB management was analyzed, and it was found for the first time that oral drugs, that is fluoroquinolone, bedaquiline, and linezolid, these are 3 oral drugs, they are more effective than the injectable second-line drugs. Very, very important finding. Then injections, kanamycin, capromycin, they found that this may be associated with more adverse reactions, failures, relapses, and deaths, again for the first time. Then amikacin was associated with modest benefits. You see, the entire concept of changing, we shifted from injection to oral regime by this, and these newer drugs, bedaquiline, linezolid, was recommended. So based on this study plus some other evidence, the WHO had to regroup the anti-TB drugs for the longer oral regime. So they defined group A, which should have all the 3 drugs, levofloxacin or moxi, bedaquiline, linezolid. Then group B, where we can add 1 or 2 drugs, that is clofazimine, cycloserine. And group C, where these drugs can be used if required, if we cannot make a regime by group A plus group B. In India, what is the treatment regime for longer oral regime today is 18 months of 5 drugs, levofloxacin, bedaquiline for 6 months can be extendable in some circumstances, linezolid, clofa, cycloserine. Linezolid we have to give initially for 600 milligram for 6 months to 8 months depending on the intensive phase, and then we come down to 300 milligram, and it has been found that the efficacy remains same and the adverse reactions are reduced. For XDR-TB patient, we go for 20 months of treatment. And what is the replacement sequence? In India, it is different than what is there in WHO based on the technical and the logistic reasons. I am not going to details. So in case we cannot make a regime after the 5 drugs mentioned there, the first replacement should be considered as delamanid. Second replacement, if we need, is give amikacin, only if sensitive, and we can know this sensitivity by second-hand LPA within 2 days. Third replacement drug is pyrazinamide, only if sensitive. Ethionamide, only if sensitive, which we can know by the first-hand LPA. Then next choice are PAS, ethambutol, imipinam or meropenem. You see, regarding the imipinam, we have used this medicine in our institute in more than 150 patients. Extremely challenging, very expensive. You need to insert PICC line, because if somebody says I have given this for 6 months by cannula, he or she is dying, let me tell you. So we have to insert the PICC line, because we need to give 1 hour infusion in the morning, 1 hour infusion in the evening. So very, very challenging, and this should be the last resort. Let us see a case. So 60-year-old male on pulmonary TB patient on irregular treatment, diagnosed an MDR-TB in June 24, and patient was given shorter oral regime containing the bedaquiline containing regime in December 24 for 6 months up to December, and but remained sputum positive, did not improve. And this is the X-ray. You can see patient has pulmonary TB, which is extensive. And the lab investigation showed rifampicin resistance, first-hand LPA, H high-level resistance, rifampicin resistance, second-hand LPA, fluoroquinolone also resistance, including high-dose moxifloxacin. Injections were sensitive, culture is still awaited. So at this stage, if patient comes, what should be the treatment? Let us summarize. 60-year-old male has received bedaquiline for 6 months. Patient has bilateral extensive disease and also fluoroquinolone resistance. So H plus R plus fluoroquinolone, that is pre-XDR TB. So what should be the treatment regime? Again we go one by one. Can we give BPLM regime in this case? All are there except that person has received bedaquiline for more than 1 month, which is a contraindication. Can we give shorter oral regime, 9-month regime? No. There are reasons being yes, very good. There is fluoroquinolone resistance, there is bilateral extensive disease, and third, patient has taken more than 1 month of bedaquiline. So because of these 3 reasons, we cannot give shorter oral 9-month regime. Longer oral regime, yes, this is a grandfather. It has to accept whatever the clinical scenario is. So it can be given, but with some modifications. So this patient was put on, these are the 5 drugs. Because person is resistant to high dose moxi, this has been replaced by the first replacement drug, that is delaminine. And treatment to be reviewed after once we have the baseline DST report available, whether other drugs also need to be replaced or not. So let us see the summary of the treatment regimes for various types of drug resistance TB. As we have seen, the drug sensitive TB, if H resistance, H monopoly treatment regime. And if we go back to this, now I can explain what is the role of each of these. So in case of rifampicin resistance, we do the other laboratory tests. If the age is less than 14 years, we cannot give BPLM. Age is less than 5 years, we cannot give bedaquiline containing regime. FQ resistance or not, if FQ resistance is present, we cannot give shorter oral regime. Extent of pulmonary disease, if extensive disease, BPLM can be given, but shorter oral 9-month regime cannot be given. Extrapulmonary TB, severe or not, if we have severe extrapulmonary TB, we cannot give BPLM, we cannot give shorter oral regime. Then mutation pattern in INH and fluoroquinolone, again if both the mutations are present, danazolic containing regime can be given, but not ethionamide containing regime. So these things will decide which treatment regime to be given. If my patient is 14 years or more, we can give BPLM. If cannot be given, second choice shorter oral regime. If it cannot be given, next choice is longer oral regime. In patients who are less than 14 years of age, first choice will be shorter oral regime and the next choice will be longer oral regime. So briefly coming to the excuse me, the innovation which we have done in our institute, I think the most important innovation which has benefited the country at large is we designed this NITRD, Central TB Division, National Task Force, which include all the medical colleges, difficult to treat TB clinic. This I started in August 20. So any case who is difficult to be treated, it is presented in the periphery. We work on a hub and spoke model. So hub is our institute. Then spokes are all over the country, including the medical colleges, district, the district centers, peripheral centers, and all of them will participate, including the authorities from the Central TB Division. The case is presented, the case is discussed. It is about 1.5 hours, and then we suggest that what treatment should be given for this patient, and also we disseminate the knowledge about the latest guidelines. And Central TB Division, if they have to pass any message to the country, they go for it. And as we had envisaged, today the entire country, states, union territories, they have their own difficult to treat TB clinic, and whenever they need any help, we are there to help them. Another thing is this Managed TB India application, which we tried in our institute with the help of my colleagues. So it is for drug sensitive TB as well as drug resistance TB. So basically it's a mobile application which takes around 9-10 minutes. You feed the patient clinical data, laboratory data, X-rays, then the biochemistry data, and it tells you what is the diagnosis and what is the ideal treatment. And one very important thing is it gives you the dosages. Today there are 19 weight bands if you see adults and pediatrics, drug sensitive and drug resistant. Nobody can remember these weight bands, and it will help you in giving right treatment in the right dosages. So the carry-home messages, my dear friends, will be we should use the genotypic methods to know about rifampicin and fluoroquinolone resistance upfront. In any MDR or pre-XDR patients, first choice should be considered should be the BPLM. Second choice, shorter oral 9 to 11 month regime, and the last choice, longer oral regime. And we must check the appropriate situations before choosing any of the regime, whether BPLM, shorter or longer, whether we can give, we should give, or we should not give. And of course, globally, the shorter and oral regimes are the preferred option. Thank you all very much for your patient listening. Thank you.